All right, sorry. Everyone hear me? Does that come through okay? All right. Well, getting kind of a late start, so I might blaze through some of these things. But welcome to the inaugural multidisciplinary case rounds. I was hoping if I went right away in June that it would be sparsely attended. Thanks for proving me wrong. It's all right. So I think we're all kind of excited about these things. It's a little bit nerve-wracking to be on here, but I think it'll be a good experience for everybody. Today we kind of went with case rounds because to get it accredited for CME, we need something general that everybody can talk about. So I wanted to present a case that I have presented before in the past that I saw in residency that was pretty interesting with hypercalcemia. It really goes into the finer points of kind of the calcium physiology. But before I do that, I think it's probably been a long time since most of us have had a lecture on calcium physiology and treatment and all those things. So what I've done is I've front-loaded this. So the first 20, 30 minutes is kind of where all the meat of the material is in. And that way, if anyone needs to step out for whatever reason, you can feel free to do that, even if it's from soul-crushing boredom from the case. But I think that way, after that, you can just sit back, relax, and not really strain your mind too much, and just kind of enjoy it for what it is. So to do that, we'll talk about kind of things you'd expect in a high calcium diet. I'm going to jump into it here to try and save some time here. This is kind of an atrocious slide, but it's hard to find a good diagram that shows everything I want to show, and I want to spend some time with this because I think if you understand a few principles, it's a lot easier to understand where the pathology is and what's happening with high calcium. So I think we're all comfortable that there's a calcium receptor and a link to the parathyroid glands, and for low calcium, parathyroid hormones released that increases the calcium. It does that in a couple of ways. So it acts both on the bone to increase osteoplastic activity, and it acts on the kidney. When it acts on the kidney, it does several things. It increases reabsorption of calcium in the later portions of the tubule. But it also will convert vitamin D from the type that we always check for vitamin D deficiency, 25 hydroxyvitamin D for the dihydroxyvitamin D. And that dihydroxyvitamin D is 125 is extremely active. It's active in the gut. It increases uptake of both calcium and phosphorus, and it also will have a lesser effect at enhancing bone breakdown as well. 99% of your calcium is in the bone, as you would imagine. Calcium is stored in the bone mainly as calcium phosphate, and the reason for that is because phosphorus with a divalent cation is extremely insoluble in most circumstances. So if you remember your factors of solubility are really, really low. So it doesn't take much phosphorus and calcium to combine and precipitate a solution. So that's why we use it for the rocks in our body, basically. Because of that, one thing that gets overlooked with talking about parathyroid and calcium is what happens with the phosphorus. So a high phosphorus will lower your calcium because you're going to precipitate calcium phosphate into the tissues. So you can think of those as kind of competing opponents. If you think of chronic kidney disease, your phosphate is going to steadily climb up. And because of that, you also see the parathyroid hormone climb up. It's not exactly that straightforward, but if you think of it that way, it's helpful to try and eliminate phosphorus. So parathyroid hormone will eliminate phosphorus and reabsorb calcium. Because if you want to think of it, the high phosphate is going to cause lowering of your calcium. In secondary hyperparathyroidism for kidney disease, you should see a high phosphorus and really a low or a low normal calcium. If that goes on for long enough in end-stage renal disease, you can see the calcium rise as the parathyroid glands hypertrophy. That's called a tertiary hyperparathyroidism. But for the most part, you want to think of the phosphorus and calcium going in the opposite direction. And basically, all the pathologies with having a high calcium are going to come down to an imbalance of these three factors. Either you're absorbing too much calcium, so something like milk alkali syndrome, where you're taking a bunch of Tums for an ulcer, or something like vitamin D toxicity. You're breaking down too much bone for many of the malignant causes for hyperparathyroidism. Or you're not getting rid of enough in the kidney. And the kidney is kind of the last stop here. So the kidney should be trying to equalize the calcium to the best of its ability. And with basically any calcemia, but especially in the non-parathyroid related high calcium diseases, you're going to see an increase in the amount of calcium that the kidney is trying to get rid of. Except for primary hyperparathyroidism. And really when you see, even in primary hyperthyroidism, that calcium go from a mild hypercalcemia into the moderate or the severe category, that's usually because you're getting renal disease. And the calcium affects the kidneys in several ways that we'll go through. But an important point is, usually it's a high calcium drives renal disease, or something else happens to the kidney, and then you get really high calcium. And that's important when we start thinking about how you go about treating this. So, thankfully, vitamin D physiology is a lot easier. You know, you make it in the skin from cholesterol, or you eat it, it goes to the liver, it gets a hydroxy group put on it, and then it just hangs out in the blood in a concentration of nanograms per deciliter, and it will be converted into a picogram concentration of 125 dihydroxy vitamin D. So extremely potent steroid type hormone. It doesn't take a lot of it to be around to have a lot of effect. There's actually 7 types of vitamin D, so that's why you have D2 and D3. They're just the most common. That's just a little fun fact. So calcium homeostasis, I'm gonna just skip through the summary there, but it's parathyroid hormone dependent in a lot of circumstances, and vitamin D is the other hormone that's related, and it's a balance of those organs that we had talked about. The symptoms in general of hypercalcemia, often very vague. They're usually chronic, mild, if you're seeing this in the outpatient world. The effect on the kidneys, it can really cause damage to the kidneys from pre-renal, post-renal, or intrinsic renal disease. So you can get nephrolithiasis, and you can get a post-renal obstruction from that. You can cause renal failure from intrinsic kidney disease, from that calcium phosphate precipitating into the renal parenchyma. That's inflammatory. You can get an interstitial nephritis from that. If it gets bad enough that you can actually see it on scans, you call it nephrocalcinosis, really calcification of the kidney. And there's a pre-renal component to it, so getting rid of a lot of calcium is going to draw a lot of water with it. So polyuria, dehydration, but also calcium's effect on the blood vessels. It's going to make smooth muscle contract, so you get hypertension with it, so you get less delivery to the kidney as well, as those afferent arteries constrict. And it causes the dehydration. I think there was another point there, but it'll come to me. So as far as GI symptoms, these are some of the more common things that people complain about. They're symptoms of slow transit, like constipation, nausea, vomiting, ileus, those sorts of things. You can get peptic ulcers, and high calcium will stimulate the proton pump. And then you can get pancreatitis, if you remember get smashed mnemonic. The H in there is for hypercalcemia, hypertriglyceridemia. As far as neuropsychiatric issues, especially primary hyperparathyroidism, it's associated with depression, anxiety, poor concentration. So there's a higher incidence there. Really, the few studies that have been done that have been controlled on treating based on that, or with surgery, or following symptomatically, have shown only a modest benefit of correcting that, even though it's associated with those things. Once you start getting severe hypercalcemia, so if you're getting above 14, you'll see people that get frankly psychotic with it. And then if you get really severe, if you're looking into the 17s, 18s, people can be comatose, and of course that's an emergency. Musculoskeletal, the really point is going to be pain. Primary hyperparathyroidism will cause bone breakdown, so you can get diffuse bone pain. Arthralgia is a common complaint. But with any hypercalcemia, you can get muscle weakness and myalgia. Cardiovascular, you're going to see hypertension. You're going to see bradycardia if it gets extremely high, and you'll get shortened QT if it gets really high as well. As far as the degrees, I've been saying mild, moderate, and severe. Those are defined. So mild is under 12. Really, you don't need to do any immediate treatment for this. You want to avoid things that will make it worse, like thiazides, lithium depletion. And you don't really need to have a calcium-free diet. You just want it to be controlled. And adequate hydration is probably the most important thing. For moderate hypercalcemia, you can either not have symptoms or have some symptoms, and that depends on how fast you got up there. They also usually don't require aggressive treatment. If they're in the inpatient setting, you can give them some IV hydration and see if you can get that down. But if it's an acute rise, you can actually get kind of severe hypercalcemia symptoms, even though you're under that 14. Severe hypercalcemia warrants more aggressive therapy, and we'll talk about therapy a little bit in a later slide. As far as the culprits or what causes this, you can see there's quite a few things, but thankfully over 90% of the causes are two things, so it's easier to remember. So primary hyperparathyroidism in the outpatient setting is probably what you'll see the most commonly. In the inpatient setting, more severe hypercalcemia you'll see as a result of malignancy. There's something called familial hypocalciuric hypercalcemia that I mentioned only because boards likes this one. So it's very rare. It's inherited. If you check a 24-hour urine calcium, it's actually low, and it's a receptor defect with the calcium receptor. So you have inappropriate secretion of PTH, and that PTH will be high normal to high despite the hypercalcemia, but you won't be eliminating much calcium through the urine. So if you have a high calcium on testing and you have a normal PTH, the board question would be what's the next step, and it would be a 24-hour urine to look for this rare entity that I think most of us won't see in our life. We talked about the tertiary hyperparathyroidism and end-stage renal disease. Malignancy causes hyperparathyroidism in several ways we'll talk about. Taking too much vitamin D or too much calcium, hyperthyroidism, adrenal insufficiency, granulomatous disease. All these things can increase the calcium, and most of them are fairly straightforward in how they do that. And we'll talk about a few of these by the end of the talk. So, for primary hyperparathyroidism, since this is the most common thing that you'll probably say I want to spend a little more time on it, you're getting an increased secretion of the parathyroid hormone that's inappropriate. You're going to see an increased calcium and a low normal phosphorus usually. And typically this is very low increases, so you're looking at 10.9 instead of 10.4. You're going to see it mainly in people 40 to 50s, but it can happen at any age. females a little more than men. And this might have a benign course for an entire lifetime. There are pretty low threshold indications for surgery that we'll talk about. Causes, again, thankfully, often it's just a solitary adenoma, non-cancerous. Assessed UV scan can help you locate that adenoma if it's clear that the patient is going to need some intervention on it. Hyperplasia of multiple glands causes, right around 20%, and then less than 1% is an active carcinoma. Thankfully, those are usually have a pretty slow course. As far as the treatment for this, there's these indications for surgery that have come out from different guidelines, so endocrine surgeons and endocrinologists are the ones I looked at. Really, if you have a calcium above 1 milligram per deciliter, the normal, that's an indication. If you have osteoporosis, that's an indication. If you're starting to get renal disease or you have underlying renal disease, that's an indication, including renal stones. There's some subtleties here as well. So even a risk of renal stones, so 24-hour urine calcium over 400 milligrams of excretion, that would be an indication for surgery. There's some other panels and things you can order, but for our purposes, that would be what you'd consider. Young age, if they're going to have to live with this for a while, and since this is their only definitive treatment, patient preference as well should play a role. As far as medical management for these very mild cases, calcium and creatinine at least annually, and then DEXA every year to look for osteopenia, osteoporosis. If they're not willing to do surgery for whatever reason, and they're in that more severe category, bisphosphate, zoledronic acid is the preferred bisphosphate for this. A calcium mimetic like cinacalcet that you usually see for treatment for secondary hyperparathyroidism and end-stage renal disease. It also helps the majority of people with hyperparathyroidism as well. There are some other subtleties to this. So if you have osteopenia and you have hyperparathyroidism, that's going to make things worse. The hyperparathyroidism will activate vitamin D, but if you have a low inactive vitamin D, a lot of endocrinologists would recommend actually treating that, but very mildly with like 400 international units and following it really closely. So I think for a lot of these subtleties, it's probably best for the patient to be managed by somebody who does this all the time, but I think we can do a good job of getting the right diagnosis and having them go in hand with the diagnosis and all the information they need for those appointments. Hypercalcemia and malignancy, kind of switching gears, there's a few different ways this happens. It's pretty common in multiple myeloma, and that's secondary to a diffuse advanced exophytic bone lesions. So once it is widespread, you can see these punch-out lesions in the skull, and you can imagine all that calcium has to go somewhere, and it goes into the blood. There's any cancer with really late-stage bone mets, you can find case reports of it doing this, but it's especially common in lytic lesions, so breast cancer, some lung cancers. Breast cancer would be the most common that you see there. And then there's this thing that they love to harp on the boards, a humoral-mediated hypercalcemia and malignancy. They're going to, on the boards, probably talk about more squamous cell carcinoma doing this, but you can also see this with breast cancers. Very rarely you can see this with prostate cancers. You can even find case reports of some lymphomas doing this as well. And then finally, there's an independent activation of vitamin D in the immune system. So certain lymphomas can activate that pathway since vitamin D is used as a signaling molecule. So several different reasons, but really high calciums do deserve a workup because of this. So that's what you're going to see more on the inpatient side for these high calciums. Acute treatment is actually pretty easy. The biggest thing is volume expansion, and you want to maintain a good urine output. You know, it used to be that these patients would come in and get 10, 12 liters and then chase that with Lasix so that they excrete more calcium, but really don't see much of a benefit in outcomes versus just volume expansion to euvolemia. And most even severe cases of hypercalcemia, because of this pre-renal component, will drop into the mild range with adequate volume expansion. If it's really high and there's some troubling symptoms, calcitonin can be used. It works in about 5 hours. It is effective in lowering that calcium. Unfortunately, it has this effect of tachyphylaxis, so after 48 hours, it just doesn't tend to work anymore. So you only use that for about 48 hours while you're waiting for the bisphosphonate to take effect on day 2 or day 3. Zoledronic acid has been shown as the bisphosphonate of choice in this case. And if they're comatose or they have severe life-threatening bradycardia, really bad renal failure, dialysis is the answer. But thankfully, most patients don't need that. So. The workup, if you find the high calcium, so I'm going to give you the up-to-date type workup of this is how it goes, and then we'll talk about what seems a little more realistic in my mind. But the high calcium, they would want you to recheck either an ionized calcium or the guidelines accord for a corrected calcium. I personally prefer the ionized calcium. So the guy who came up with the corrected calcium formula, Paynes, in 1973, his original paper had 3 cases of hypercalcemia. It was mostly hypocalcemia. And in 2009, there was a follow-up study on that, and it found for hypercalcemia, because this curve is probably not linear, it underestimates the amount of hypercalcemia by about 50%. In 50% of cases, it underestimates it, excuse me. When they look back at that data in follow-up studies, it's usually when the albumin is high or high normal, or there's a paraprotein anemia. But just to eliminate that, you know, I prefer the ionized calcium, even though it's more expensive. For hypocalcemia, it's still good to get that corrected calcium. It's still adequate. If that is elevated, they recommend checking PTH. And then if you actually read in the guidelines or read in the body of up-to-date, age-appropriate cancer screening and chest x-ray at that time are also appropriate. Once you wait a week and a half for your PTH to come back from the outside lab, if it's high, they would like you to make the diagnosis of primary hyperparathyroidism. If it's normal or low high, they want to check a 24-hour urine calcium for the familial hypocalcemic hypercalcemia. And if it's low or even just lowish, they want you to move on and check the parathyroid hormone-related peptide and both the inactive and active vitamin D. And this is one of the only times you're going to check an active vitamin D level, the 1.5 dihydroxy. So if the parathyroid hormone-related peptide is positive, you go on a malignancy hunt. If the 125 dihydroxy vitamin D is positive, you go on a malignancy hunt and you consider granulomatous diseases. And if you have an elevated 25 that hydroxy vitamin D, that's taking too much vitamin D. If all those previous tests are normal, they want to move on to SPEP, UPEP, serum-free light chain. If that's normal, TSH, and if that's normal, vitamin A. So if you go by their recommendations, you are going to poke your patient about 9 times, and you are going to get your answer in a few months. So if the calcium is just mildly elevated, that's probably okay. But I think after the PTH comes back, which I typically order after the first calcium if it's significant, well, again, an ionized calcium, I think it's reasonable to do a lot of these other things at the same time. To really, one, it gives you peace of mind that you have the right diagnosis and something that can be associated with malignancy, but 2, from a patient satisfaction point, not pulling them in and doing that every few weeks to get a diagnosis is that expedited workup, I think, is appreciated on their As far as what I want you to get from this talk, it's pretty simple. The calcium metabolism, controlled by parathyroid hormone and vitamin D, is this balance between the GI system, the bone, and these renal factors. And the first step to working it up, if you're going by the book, is rechecking a calcium. I recommend the ionized. And then if that's elevated, get the PTH level. For those of you outside of primary care, I would probably just recommend getting the ionized calcium and the PTH level and get them to their primary care physician to do kind of the rest of this workup and come up with a diagnosis and decide where and if they need to be seen, if it's oncology or whoever they need to see. The immediate treatment is going to be volume expansion in the vast majority of cases. So if you can remember that as a first step, that should buy you some time when you figure the rest of it out. I think, I probably still have time to go through the case in some depth, but I'm going to try and skip through that pretty quick because of our computer malfunctions right away. As far as questions at this point, is there anything that people want to make sure you answer? All right.
I guess one of the questions is that kind of a common scenario we have is the 80-some-year-old woman who comes in with that calcium of 10.7.
Yep.
And where do you go from there? I mean, they may or may not have osteoporosis, but
yeah. So you have to decide what their life expectancy is. At 87, it's not going to be 10 years usually in most cases. So I think being judicious about this and maybe just watching your calcium is reasonable. If you're worried about cancer, or they're pretty healthy and they're doing pretty well, I would probably go down the PTH route first. And if that's just mildly elevated, I would just watch them and see how they do. It's probably never going to be a problem for them in their lifetime. If they're not on treatment for osteoporosis, what's the benefit of that going to be? Since it takes time to work, I think you just have to put that in the forefront of your mind, talk to them, and kind of decide what you want to do. I don't know if I have better advice than that.
yeah, but it's pretty common where we see that.
Right.
Just trying to look through that and figure out what's the right thing to do.
Dr. Mosier, do you have anything in there?
That's what I.
So this case is a 66-year-old male, and he's having symptoms of MSS, constipation, fatigue. His history is coronary bypass and type 2 diabetes. He had a lung abscess in 2013 due to diabetes fold. He doesn't do things he's not supposed to, as far as smoking, alcohol. He is on Invokana and newer diabetes medications that makes you urinate glucose. Otherwise, everything else is pretty reasonable for what you would expect him to be on. He called his PCP and kind of a tougher guy for symptoms. He's been vomiting, really constipated and fatigued for about 3 weeks before he called him. He was reading side effects in Invokana and is pretty sure that's what's doing it, even though he had no issues up until 3 weeks ago and started over a year ago. So he was going to stop that, and he was going to follow up in clinic when he had time to get labs. And at the lab appointment, he had new onset renal failure. Previous creatinine was 1.0, and now it's 3.1, and calcium 13.1. So he was told to go to urgent care. At the urgent care, really no history that suggests cancer or suggests infection. He did feel better after stopping the Invokana, but not 100% yet. Really nothing on physical exam other than hypertension. And they felt he probably should be admitted for this and get to work up. So nothing new on the H&P. They gave him 2 liters of normal saline and they repeated the labs. And kind of like we talked about, his creatinine came down by 1, so there's a pre-renal component. And his calcium came down by 1 as well. Ionized calcium was elevated. The parathyroid hormone I have listed here, but it didn't come back until several days into the hospital. But that's going to come back as undetectable. And you can see that the kidneys have some blood and some calcium oxalate, so they're not too happy with this high calcium. They felt he had acute renal failure. They felt that there was also hypercalcemia, and they felt the hypercalcemia was secondary to acute renal failure. When you don't see this every day, these really high calciums, it's easy to get in your mind mixed up this mechanism, but really it's usually the underlying propensity for hypercalcemia, which often will precipitate the renal failure, and then it gets worse. Usually it's not the acute renal failure causing the high calcium de novo. They were going to give him some hydration, hold his ARB and hold his metformin as appropriate, transfer to someplace with nephrology if they needed to later, and get a CT of the abdomen pelvis for the renal failure and potential for malignancy. That showed splenomegaly, it showed stones, it showed bilateral renal cysts, and showed aneurysm, which kind of explained his symptoms. He had slow to borderline improvement. They felt that maybe the symptomatic was playing a role. There's a couple of case reports that could increase your calcium, although not super significantly. Continued dehydration. They did try calcitonin. The creatinine didn't really change after the initial resuscitation. The calcium did come down after the calcitonin, down into this more mild category where it was when he was discharged. So they wanted to follow up with his primary. And after that PTH came back, they ordered peripheral smear, ordered the vitamin D, parathyroid related peptide, and they reticulocyte count. His 25 hydroxyvitamin D was low, so the inactive and the active was 2 times the upper limit of normal there. His related peptide was negative, reticulocyte count was normal for what you would expect. His smear did not show any evidence of malignancy. Really no history that was contributory, other than he was feeling a lot better after his hospitalization. His calcium was not improved, his creatinine was a little bit worse than discharge. His PSA was normal, and they gave him bisphosphonate. They were going to get him in to see nephrology and internal medicine, and ordered an SPEP-UPEP. His SPEP-UPEP showed elevated free light chains, but his lambda free light chains were the upper end of normal, which made his ratio just at that upper end of normal. So I felt this was probably due to renal impairment at that time. He got some follow-up labs in 3 weeks, and his creatinine had bumped to 4. So then he was sent to hospital with nephrology to decide what to do about this. So, really no history. He was actually feeling back to normal at that point. The hospitalist was going to get a CT chest for malignancy and get a renal consult the next day. Renal ultrasound was negative. CT chest had some scarring where that previous abscess was, nothing else on that. So his creatinine didn't really improve much with fluids at this point. Nephrology brings up this point that with granulomatous disease, you often see this high activated vitamin D, and that's for reasons of the immune system mediated activation of vitamin D as a signaling molecule. The other thing that was brought up is this capillite chain. Is that significant or not? So was wondering if we should get an oncology consult. He was also noted to have some nephrocalcinosis when he reviewed the CT scan. Creatinine, while it looks improved here, if you look at my scale here, it really, from an S-GFR standpoint, didn't improve much. And calcium hung out in this mild category after dehydration and stayed there. Oncology didn't feel there was any reason for to suspect malignancy, but if we didn't find anything else, was recommending a PET CT. As far as the next few days, he's given another bisphosphonate, didn't really get improvement. He had an elevated ACE level. He had a normal test for tuberculosis, his LD was normal, and nothing new on the urine fixation. So it was decided to go forward with the PET scan. And the PET scan here was fairly significant. So it's really easy to see this right engorged spleen, but there's also some reactive lymph nodes down there. You'll have to trust me on that. And if you're picking a place to go get a diagnosis with a biopsy, you probably don't want to pick the big engorged spleen if you have a lymph node there. There are some non-specific findings that we don't need to go over for the sake of time. So despite not having any chest findings, pulmonology was consulted given the concern for sarcoidosis, given the high ACE level. So the pulmonology felt that was potentially the case. They discussed with interventional radiology, and they were able to do a fine needle aspiration, but if this lymph node was right next to the external iliac nodes, they didn't want to use anything that was larger than the fine needle aspiration. Thankfully, that gave this result of a lymph node, and here you can see some nodular calcification, but here you can see non-caseating granuloma, which is significant for, or suggests this sarcoid disease. Is that right, Greg?
Yeah.
Okay. They also found, just incidentally, some soft tissue there. They just found massive amounts of calcium in soft tissue from having this high calcium for so long. So all this is calcium phosphate that just poured into his tissue. You can imagine what his blood vessels look like after a couple of months of all this. The GMS stain was negative, and it was felt this was sarcoid. He didn't really have improvement by the time of discharge, and he was starting on 60 milligrams of prednisone right before discharge. And he was going to follow up with his primary pulmonology and nephrology. It was felt that he probably needed 1.5 to 2 years of a prednisone taper for this. So he actually had normalization of his calcium and creatinine within 3 weeks of doing this, which is quite impressive. And if you have normalization of your creatinine within a month of diagnosis with sarcoid disease and with hypercalcemia, that portends a good prognosis for you. You'll just have to take my word on that at this point. But a lot of his disease was actually probably granulomatous interstitial disease from sarcoidosis because he had so much reversibility to his renal failure. Unfortunately, his diabetes was way out of control, which is kind of where it stayed since the last time I followed up on him. So in March of 2018, he was still on 17.5 milligrams of prednisone in A1C of 10.7. If you look at its calcium, you can see when prednisone is initiated, it comes back into this high normal range, and with the initiation, the creatinine normalizes, although his estimated GFR was at its baseline because kidney disease stage 2. I just thought that was a really, really interesting case, and there's a lot of other points I wanted to go through, but I don't think we're going to get to them. The history of this is really, really interesting with treatment of tuberculosis and granulomatous disease and vitamin D. But basically what happens for the mechanism is, from what I can piece together, is that you get this Th1 immune response from this unknown antigen in sarcoid or from tuberculosis molecules or an endemic fungi. And that's going to cause some Th1 cell expansion, and both those things are going to cause macrophage activation and recruitment. And the problem with granulomatous disease of whatever form is that this antigen can't be cleared. So you have this persistence of the antigen, so you have this process just being driven over and over again until you get macrophages that are laying on top of each other, causing this granuloma. The macrophages are going to increase vitamin D, and the reason they do this is because part of this pathway to activate them activates a 1-alpha hydroxylase, and that's going to increase some proteins in the macrophage to increase bacterial killing. That also goes back to the Th1 cell and turns off that signal response over about 24 hours. So it actually works in a kind of negative feedback mechanism loop, and if you don't have a driving force behind this works pretty nicely. But if you're not going to clear your antigen, you just get all of your 25 hydroxyvitamin D shunted into your 125 dihydroxyvitamin D, even if this is not in the kidney or parathyroid hormone directed. So it's kind of an interesting mechanism overall. Interestingly, for people with extrapulmonary sarcoidosis, the risk for developing hypercalcemia is what this guy was: male gender, greater than 40 at diagnosis, and being Caucasian. So this guy's happy about his hypercalcemia sarcoid. That's just saying that kidney disease we talked about a little bit, and treatment is basically the same for acute hypercalcemia no matter what the cause, and then you want to go ahead and treat the sarcoid disease as you would normally. There's a couple of other things you can do if they have spontaneous prednisone. And typically for parathyroid hormone independent mechanisms, one I would avoid would be replacement, because that can often make things worse. I'm going to skip kind of all those closing pieces. I don't know, are we going to make this available online? Is that kind of the plan? So you can go through some of that if you want. Sorry that's cut short, but I think that's probably about where people's attention span can handle anyway. So.